We will go to our first panel on hormonal therapy. Our panelists are, they'll speak to you about the interest of the benefits of hormonal therapy and other initiatives in order to alleviate any pain during the treatment. I remind you that you can go on Slido and ask your questions, which we will get to at the end. At the end of 45 minutes, I will invite you to ask your questions, and you'll have the opportunity to ask your questions at the microphones in the center of the room. Let's invite our panelists. Professor Sophie Lauzier. She's at the Université de Laval. She's a researcher at the CHU of Quebec and Université de Laval. Dr. Jamil Asla, who is an oncologist, medical oncologist at the McGill University. He is also a president of the scientific committee of Groupe McPic-Sirois. And Marianne Côté, who's working, she's a partner, Marie-André Côté, partner, she's a partner, a patient partner with the CHU, as she also has a breast cancer and will be the moderator of this panel. I will now leave you. Have a great chat. And yes, we can applaud them. Hello. Thank you, Martine. Hormonotherapy. What a hot topic to start the day. Hormonotherapy is often prescribed during the hormonal-dependent cancer treatment, which represents 80% of breast cancer cases. A qualitative analysis has declared that patients who benefit from hormonotherapy request more information, continual information, in order to understand the therapy itself and to also understand their own risks when it comes to the illness itself, in order to prepare oneself better to the secondary effect, to the side effects. Why would one turn to hormonotherapy, and what are the benefits? I'm quite happy that you answered only 1% of the oncologists, because you are the most important element in this. Breast cancer is very complicated. There is not one breast cancer. There are plenty breast cancers. There are some that are in situ, and there are some that are invasive. In the two types, hormonotherapy is prescribed. There are benefits for both. In situ is in terms of prevention and has great benefits, but we can also have deeper conversations on the in situ benefits. When you have, for example, when you have the cancer and it is in vitro positive, we will proceed to that treatment because we can prevent relapse. We do not want our patients to have relapses, and so we explain hormonotherapy because we want the hormones to calm down, and we don't want to stimulate them too much. But in these estrogen-positive cancers, we've identified some where the treatment can be very beneficial and others where it won't be beneficial. In all the other cases, depending on the benefits, even if the benefits are low, we will prescribe it because the tolerance is pretty good. So there'll be a small benefit, but because the survival will be long, because there are benefits to survival, we will use it. And we have the opportunity to live in a country where people live very long, and so this treatment can be continued. When the benefit is small and the quality of life is unbearable, well, we will try to make some compromise. We'll try to lower the doses. The issue is when the benefits is important and the tumor is more aggressive. This is when we don't want to make compromises, but we have to listen to the patient, and we'll try other, medicines against heat strokes. There are many things that can help reduce side effects. Apology, I said heat strokes, but rather heat flashes. Questions will follow. What are the different types of hormonal therapy, and how do they function? How do they work? Is this for me, or is this Professor Lauzier? I'm going to leave you the question. There is a classic cocktail of the sort of anti-hormonal treatment, which is the estrogen one. So the tamoxifen is the less toxic one, but there are many patients who complain about side effects. The anti-aromatas are prescribed for patients and tamoxifen for those who have had menopause. Now, for those who are in premenopause, we can prescribe classic hormonal therapies. How do we determine the length of a treatment? That is the question. It's $1 million question. The oncologist would like to take hormonal therapy as long as possible, but in situ cancers or illumini that has very strong estrogen would impose a 5-year treatment. And in cases of stronger cancers, there is no limit. But after 7 years, we kind of get comfortable. After 10 years, we get even more comfortable. And those who have no side effects are recommended to continue on that treatment. And so the literature, the research on it suggests 10 years. But many oncologists do believe that we shouldn't stop the treatments. But there are also side effects to this hormonal therapy, even though there are no symptoms apparent. Hormonal therapy plays an important role in the reduction of risks and relapse, but we can also, in order to have more benefits, it is important to adequately take the treatment. Up to now, the research and literature suggests that up to 30 or 40% of patients stop it on their own decision without consulting the care team or do not take it adequately. Professor Lausier, why is it so difficult for certain people to take this treatment? The addition to the acceptance of this treatment starts with 3 things. Some women will not want to take it because of the length, because of the heart. So it would be prescribed to 5, 7 to 10 years. That could be difficult. And also the fact that it has to be taken daily depending on the prescription. Many studies were conducted to see what are the factors that are associated to the approval of or the taking in of the treatment. There are people who studied age, the state of the cancer. But what we've seen is that the factors that affect compliance are factors that we called psychosocial. These are modifiable factors and on which we can actually work on. We found that in the literature that to have understandable information can influence compliance, but also to know that there are going to be some undesired side effects will also encourage compliance. To also understand that you may be prone to relapse and that the treatment will be helpful also ensures compliance. And there are also other factors that are associated to the relation between the patient, as we saw it before in the first presentation, between the patient and the care team. These are factors on which we can also work. How can we embed the compliance to the hormonal therapy, Professor Lausier? As I said before, there are many determining factors that will affect it. The interventions must be multifactorial. What we know also is that the interventions that will work are those who will inform the patient very well, but also when the patient understands the medicine, the treatment that is given, how to take it, when one is given the proper information on how to take the medicine, what is the side effect, is another thing that ensures compliance. The other element to consider is capacities. Is someone able to establish a routine? Are they able to maintain that routine or even plan trips during that routine? What is the capacity of that patient to face urgencies or issues? Do they know does the patient know about the real side effects? Are they able to report it to the care team? And are they able to find strategies? The other element to take into account is motivation. We're in a context where we are trying to prevent an issue, and so we do not have the tangible effects on that we don't have the tangible effects as we speak concretely. So what do? We have to constantly remind the potential benefits on the benefits of this treatment, because the idea here is to make a balance between the inconvenience and the benefits. And if a person experiments much difficulty and that the benefits are not in the balance, then we will not be able to ensure compliance. And the last thing that I would say is a very important dimension that we have to consider when we intervene is the emotional and affectionate element. As we start the therapy, we do know that our patients have gone through many hurdles. Certain patients will have a treatment, see the treatment as hope, as a chance, as a chance to take care of oneself. And for other patients, treatment is a reminder of the illness. And so we must take these elements in account. And I will allow myself to add a little something, a little point that might help in the motivation into the compliance. Is also to talk. Another thing is to talk with people who have used this treatment, who also are going through the same treatment. And many of them are going through, because for someone it can be awful, and for other people it can be an okay experience. And so to discuss with someone, I'm going to make a little ad for Paroloco, who have different people to accompany one, but there are also different locations in Quebec where they operate, and there are people in the foundation to which we can also talk to, such as the Breast Cancer Foundation. We'll now see a video. We consider that there are some different factors that can affect whether someone will take the treatment. As we said, the impacts on the quality in life is extremely important. We will listen to the testimony of Suzy Matteau, who is a survivor, and she really faced a lot of hurdles with this treatment. But she found solutions.
My name is Suzy Matteau. I am 55 years. In 2021, I had this diagnosis of breast cancer. In December 2021, I had this mastectomy and reconstruction. After that, we had the COVID, and then I had another mastectomy and a capsulate. And then after that, I started with the treatment of hormone therapy. When I started the hormone therapy, I received the prescription by the oncologist. I wanted to discuss about that. I don't know if I received the information on the side effects or tamoxifen, or it's just because I didn't assign that I was not prepared. The side effects started. It was very strong, and the emotional, physical, and psychological level. I didn't understand what was happening, and the impacts were greater, and it was really hard. I was not able to work, and then because I had this health insurance. And I understood that I was not covered by this type of cancer because it's not considered a severe cancer. So I had this emergency in order to retake health and to go back to work. So after that, because I wasn't sure about the side effects, but I didn't understand. And of course, I was more anxious about that because I didn't understand what was happening. And then with the tamoxifen, I was panicking all the time. And in fall 2022, I didn't see any reduction, any improvement of these symptoms. And on the contrary, I was physically and psychologically even more ill. And then after tamoxifen, I was just steady. I was blocked, and I started to talk to my family doctor and the private nurse. I had some answers, but they were not complete. and then I went to talk to the Department of Oncology, and I had this community pharmacy. And in the community pharmacy where I normally take my drugs, and then my medicine. So we went there. I was validated with what I thought. I had the answers, the confirmation, the discussion. Yes, tamoxifen may provide this and this and this side effects, and so for it was clearer. And when everything was more clear, then it was easier because I could take action, and the pharmacist who followed me up all along the process and the validation. And also we talked a lot, so that together we had this list of side effects, what would be the elements in order to reduce the side effects in the pharmacologist level, and also the accommodations I need to make. And what I also had my appointment with the oncologist. It was important for me to have this information, so I was able to control the situation. And then after that, in the fall, the tamoxifen, we understood what happens, but I started to retake it. But it was only gradually, and the first time the amounts were very, very small. With the research I made, I started validation that said that but for women who are not very well informed, that explain this bad treatment. And I say, okay, I was relieved, and I was concerned by this phrase, because women who are not very well followed up, because we are not informed, it was difficult. But now I appreciate this follow-up. The work with the pharmacist was very important. I went back to tamoxifen, but in spite of all these happenings, the side effects were very strong. And in May 2023, I decided to start to stop. So I took this decision with the pharmacist. We assessed the situation, and we didn't see any treatment. So for me, in 2023, it was the end of tamoxifen. So in my case, what was important is the collaboration, the team work with the healthcare professionals and the community pharmacists, because that I was supported. Thank you. Thank you, Ms. Mato, for these statements. And so it was important for me. I had hormonotherapy since 2006, and then I had this treatment of hormone therapy, and I didn't see any side event. So we need to have all this information, and we need to have this series of people who react differently to the treatment. Maybe for the decision, it is important to discuss with the patient, of course, to listen to them. We didn't have time to listen to them. But this is a multidisciplinary team. The community pharmacists also, they have a very important role and in this spectrum. We have these witnesses of Madame also. It is important to be followed up and informed, so productivity should be there all along the process. As we see that the patient that need this information, and all along the treatment, and the hormone therapy that is described here, as Mrs. Mato has mentioned, this is a period where the women feel abandoned, because we have radiotherapy and then the chemotherapy, but after that, when we have this hormone therapy, we feel abandoned. A professor who is going to guarantee the follow-up during this hormone therapy. This is a multidisciplinary team. I would say we shouldn't stay on our own on this problem. And then when we meet the professionals, then we need to speak our mind, and sometimes we need to question their treatment, and the health professional will be able to follow up. And also, if in this case, I think this discussion, it should be very honest on what we feel, and then with people who can follow up with oncologists that are part of the process, and the people who follow up the treatment, and then we can talk to the pivot nurse. This is also part of the important part of the team. We can talk about the sexologist, if we have side events there, so we can establish this link with the family doctor. So women have appreciated to be in contact with other people who had also took this medicine. So it could be an important source of support. I think also for the information, the contact with people who have experienced the same process or treatment, it is very positive and very important as well. Now, and different solutions that have been explored, which are the main strategies to try in order to reduce side effects. We can take some action. We say we have the good lifestyle, sleeping, and physical activity. It depends on what we want, but it all helps. And we have some complementary treatment. We see some evidence in the scientific that acupuncture may help with this. With these side effects. This afternoon we'll see this, and when the side effects are difficult to manage, we have some pharmacologist actions that may be applied. For the healthy lifestyle, physical activity, also good sleeping, and sometimes we change the medicine. This is something simple. Sometimes we have Adikimidel, and sometimes we just have different effects. But if we just take that, sometimes we just it works. We have seen some patients that have appreciated that. Then if we can change also in order to talk to other experts. We have a lot of support. If we don't have this demand by the professionals, it is important for the patient to be proactive and to talk to other actors and experts as well. We should be proactive from the beginning. It is always important to set this question: is there anyone that can help me? Is there a service that is available? We should not hesitate to talk about side effects. When we have side effect that is undesirable effect, they will impact the quality of life and work life. It is worth a discussion on that in order to reduce this undesirable effect, even if the impact is on the lifestyle and not in the physical or other effects. It is important because there will always be service available or professionals that may help us. Then I think you have already answered to these questions. Could you adjust the prescription when we talk about changing molecules, and can we probably reduce the dose to Madame Mato? So for this cancer, yes, we can change the dose, but it depends of the how aggressive the invasive cancer is. But we need to see for the. I try to go to the same sources to keep the same dose. We know that hormone therapy may have these side effects, but in the menopause as well. Is there any way of have this pause when in menopause we need to see this? Can we maybe mix the effects or the consequences of menopause and the hormone therapy? Maybe we can mix them up. We're not sure, but sometimes we need to stop taking specific medicine for 2 or 3 weeks, and then we can see what happens. Well, because the comprehension of the impact of hormone therapy, it is essential for decision taking, free and informed decisions. So the risk of reprisal, when we see of relapse, the risk of relapse are some notions that are difficult to understand for the patients. People want to know what is the meaning. We talk about the risks, but we're talking about some risks that we need to know in order to take an informed decision. How is the patient going to receive this kind of information? Okay, I can mention now the general principle. Of course, the women have different needs. Some women will want to know everything. Some other women just don't want to know. So it depends on the characteristics of the cancer and also the preference of the patient, which is important, and in order to adjust to what happens and as information. But in our research project on the addition to hormone therapy, we will present this in a different way. But the management of risk is different. There are some, we've seen some studies with tamoxifen, but this is a discussion that should be adjusted to the preference of each person. We can probably explain how it works. So we had this clinical research, which are the women that have been included. We try to individualize, but most times we have these patients, and then they have these characteristics. They haven't been included in this clinical study. And then it is the base in order to produce some figures and the benefits for hormone therapy, and then we can make some adjustments. So one of the tests there in order to have these benefits, but you are not going to have. We can do this in order to avoid a relapse. It is important. We can adjust to we want to have every single case. We don't want to take the statistics and that's it. No, we want to take this on a case-by-case basis. So we can, of course, improve the immunity system. In order to see a more optimal treatment, it is important to take it case by case. And the risk, which is relative, in order to vulgarize this term. It is difficult to undertake this with no illustration, but the risk, absolute risk, is the example that I provide, and we can use a group of 100 women, and then within this group we take in the tamoxifen. We need to see how it works, and not another group of 100 women to see the difference between these two groups, because the second group didn't take the tamoxifen. Which are the developments, more recent developments in immunotherapy for the breast cancer, how this can be changed, when we can address the treatment. There are some advances, but we will still see the side effects. We see these advances. We started with clinical research. We start with the worst cases, and then we go to the first cases that are at early stages. And then we are going to publish. We have this with the hormone therapy. We have this link and this that we are going to take, and this reduce the risk of relapse. And then this is for the, at least we see the benefits, and we are going to use the pivot nurse, because they don't have these side effects. But there are many people that are not happy with this medicine, but so far it's provided good results, and we see the benefits, and we heal people. Maybe we can now take questions from the public, from the audience. If you have questions, you can introduce yourselves. We have 2 microphones here. You can ask your questions. Maybe you want to take your time. We're going to take all the questions. We have some questions on Slido, but of course, people here. So we start with the questions from the audience, who is present here. I don't know who came first. Can you hear me? I don't know if it's something that you can answer. I'm 49 and I'm going to start the tamoxifen in the following weeks, but I am going to be in menopause, so how I'm going to make sure this tamoxifen, what is going to determine that, because what is going to determine that I am going to change of medicine. Yes, but your oncologist will follow up with tamoxifen. It's a good drug, so it is not because we're menopause we're going to change of medicine. So you're going to receive this follow up. It depends on the tolerance and risk level. If your tolerance is okay, if tamoxifen is going to be a good medicine. We are not necessarily going to change at the beginning. In the past, yes, we used to change that, but not now. And then you are going to see the switch after confirming menopause. So we can see that even in menopause, yes, and 2 or 3 years of tamoxifen, and then we can change. Thank you. We talk a lot about side effects, but what are the side effects? Which are the side effects? Is it difficult? It depends on what tamoxifen. There are a lot. The classical, the chaleur, and then sometimes we have embolia. Especially for women that are in risk of thrombosis. There are some others that are very frequent. and then we can do the follow-up, gynecological follow-up. But it works well for most people. We have a lot of side effects, but the plus frequent are this. Also, the vagina dryness as well. The pain, articular pain, change of libido. We shouldn't hesitate to talk with a professional and this. Bonjour. I take letrozole for 2 years, and we have this muscle pain at the beginning. I was not able to go into the escalators, and we also have I have been organized in order to cope with this, but I take the CBD medicinal, c'est une magique. CBD, yes, we continue. The problem is also dry vagina and also urinary infections. I have finished treatment of antibiotics, and I will restart, and I start another infection. Can we take the bioidentical hormones? I've read that progesterone could be effective. For the estrogen, is difficult. For estrogenous, is very difficult, but for local, like creams, yes, there are no problems with that. But not the dose that are going to be going to the systemic circulation. So this is why we are not very happy to use estrogenous. But with the cream, when has been prescription, but my oncologist doesn't want to. That is the cream. So this is the discussion case by case. I don't know if you have. This is the lifestyle for the dose. You should talk to your gynecologist. I think there should be a solution. I can also, if there is a special file in the website of the CHU that has been written by the patients with sexologists, so we can see that with in order to verify that. But there is a treatment with a laser that has been accessible in Quebec. It is not refunded, but that exists and that works. So we see that in the website of CHU. Thank you. Good morning, everyone. I am going to read my question because I had sent it in Slido. You have mentioned at the beginning when we want to avoid metastasis of the tamoxifen, we can talk about the variectomy. The variectomy is irreversible, and this is a very effective treatment. If we don't see side effects, then we can do, depending on the type of cancer. For the patients with a positive development, then they can support that. I could do that. But at the level of the studies so far, it is important to take that. I would have liked to have this answer before on the benefits of Rebo. It hasn't been approved in Canada. I think you talk about I take the Kisqali. For the side effects, these are the benefits. This is for the benefits in order to control the illness. This is for the progression and the control in order to improve the survival. Before taking the floor, I like to mention that we want to take a lot of questions in this treatment, but I think it's your team that is going to help, because here in the panelists they don't have all the record, the clinical record of health. But if we can go to be a bit more general, that is even easier. Thank you. Yes, I see. All the time I have these side effects. Menopause is the same, has the same symptoms, and for what happens before the cancer, we know that in premenopause is 40, 45, but we see a lot of hormonal imbalance. But we see the progesterone. Do you have this part in order to rebalance that? Is it the imbalance that make that we have this incidence of cancer when we are 50? We don't know. In Canada and in the world, if we talk about the prevention, the best tool is the hygiene, education on the sport, good lifestyle. That is the base for us, and then we can go to the detection in Quebec. Then we need to see these studies, but I don't know if there is one that fertility and to stimulate that. These are the patients now with breast cancer, but there are many elements that we don't know yet, so I cannot provide a complete answer, but there's no choice if it's just that there are so many factors at stake when we talk about the causes. But now you see that there are more young people, so this is the normal hormone system, right? Yes. So maybe I'm not sure why we have more incidence of cancer in young women.
I'm taking letrozole, and my relapse percentage is 32%, and I have a hormonal dependent to estrogen cancer. I have a good life hygiene. I eat very well. I do a lot of exercise, but I have some particular side effects, which is insomnia. Is there a particular time where taking letrozole can help with this insomnia, or is there another molecule that could affect positively insomnia and reduce it? I am not aware of the effect of that medication on insomnia. So sometimes what we would do is you'd skip a day, and then if you know that you have issues at night, you try to take it in the morning to see what happens. I think that's the best way for you to go. But for other medicines, we can try to change the class of medication that is given to you. Once again, try to see your oncologist and see how you can adjust your dose. Do you know a different molecule? I mean, maybe you don't particularly know them. There are not some known molecules that can affect the insomnia because there are no warnings on insomnia on the labels, but it does exist. So insomnia comes with hot flashes that may induce a state of awakeness. If someone has a cancer with the tubular A and 100% estrogen, do they need the hormonal value therapy for a couple of years, or should they continue? Unfortunately, I'm going to have all these types of, I'm going to have all types of oncologists on my back. So tubular is sort of a good cancer. In the retrospective studies that we've had in the past, notably with the Scandinavian, we noticed that things are good after surgery. And so I would be very flexible with you. I would recommend you that, right? But if you had any side effects, I would stop them. I would stop treatment. Thank you very much. Hello? I have tamoxifen. I have a cancer that is 95 estrogen and 5% progesterone. And from what I hear here is that the medication you're proposing is only an anti-estrogen one, right? When in terms of the progesterone, what blocks the progesterone? Now you are going into a delicate question on progesterone. What does mean progesterone? The progesterone receptors are being debated, but we are mostly affecting the estrogen. With the tamoxifen, will have a better impact. Pure anti-progesterones do not exist. It really, tamoxifen will do the job properly. And so this is a predominant estrogen. Well, as terms of progesterone, you have, for example, a progesterone at 98% is a good factor. It would be a good, it constitutes something that we have good biology. Well, it's good to know. Yes, it is good to know. Any questions? Are there any studies to analyze those that do not have side effects? Is there something in their DNA that could offer us, I don't know, a pathway to develop a new molecule or something? I find your questions to be very pertinent. I'm not aware of any studies on biology that will ensure no side effects. I take note of the question. Unfortunately, I cannot refer any studies. But that does help us with different reflections or different discussions that could be entertained upon the subject. What do you think about musical therapies of 10,000 hertz that apparently or that can eliminate cancer cells? Would anybody have an answer, or would anybody... I have no knowledge of this method. I don't know if you... Well, anything that could help the patient. We're talking about high-dose vitamins, like injections of high doses of vitamins is something that I'm against. But I don't have any counterindication to... I don't have any objections to listening to this music. But if there is a demonstration... I would be interested in it. If it was evidence, I would recommend it to everyone. So, but I would like to see interesting data towards that. But there are millions, there are thousands of comments on this type of music where people have had medical treatments against cancer and heal after a few months. Obviously, we work in a scientific manner, and so we are trying to see... I'm listening to this music daily, and I honestly feel like there's a huge difference, which is really well. But I cannot, and I understand what you're saying, but I cannot ensure that one will totally heal with it. At the hospital, I cannot recommend it medically speaking. But patients who propose us this type of thing is not something that we're against. But if it heals people and it doesn't cause any undesired side effect, it's fine. So someone, I'm just using this question because I know of someone who's had cancer and who has healed themselves with that. But of course, you can hear a lot of things. Speak with your oncologist, but I really doubt that your oncologist would be against it at all. So it should be fine. Thank you. Hello. Thank you very much for this conference. I have a question on the origins of cancer. I am in remission, and it was a cancer that was detected at 35 years old that was hormonal dependent with a very positive. I'm on amoxicillin and Zonadex. I started Zonadex during my chemotherapy to preserve my fertility, but it was the recommendation of the oncologist and the amoxicillin. I've been taking it since April of 2021 after my radiotherapy. It's very difficult, I have to tell you, especially when we were announced a reduced length of the Isoladex, and with the years, throughout the controls, we are asked to add another year, 2 years, 3 years, and so it's really difficult. And then according to the literature, we are told 10 years. Now, what is it? How long are we going to tolerate this medicine? Are we able to tolerate it for life? I would really like to ask the question again on the origins of cancer, of hormonal-dependent cancer, especially if the woman is young, because we ask ourselves the question, as soon as we get a diagnosis, we start asking ourselves questions. Will the management of emotions Is the management of emotions a risk factor? Because I have put up a list of everything that I wasn't doing well, and I was thinking to myself, maybe it has to do with that. The fact that you work on emotional management, it could give me more strength to not fall into relapse, because to just start my hormone and to alterate my daily life in a drastic manner, I'm not sleeping. I haven't been sleeping since July of 2020. As we speak, I'm having hot flashes. I'm constantly taking my clothes off. It's extremely difficult. And I'm not talking about mood changes. It's been very difficult. I've worked on it. I've done a lot of work in order to find some normalcy, some life, but these side effects are extremely hard to handle. When I walk, my articulations hurt, my joints hurt. When I want to stand up, it hurts. I'm 39. I'm in a good health. Everything's going well, thank God. But I would like to know, can we work on other factors that could reassure us on the absence of relapses? Because to take a hormonal therapy does not mean that we will not relapse. Are side effects irreversible? Because the side effects on my body are hard, and I've tried everything and I have no answers. And when I speak with my doctors, it's as if they were saying, well, you just have to accept the consequence. So, yeah. So, mood management, emotional management. When we were talking about those who take it for 10 years, or for those who tolerate it well. In your case, it's very difficult. I would not advise you to take it for 10 years. I would talk about my side effects with the oncologist, because, as you know, we won't prolong this treatment indefinitely if you are living in hard situations. After 5 years, we'll review things and discuss and see how we can change things. Emotions, of course, it's really important. Stress as well. I think that some people live with less stress. There are studies on animals, and we can see that cancers are reduced. But these stress factors are not to be ignored. They're real, and we take them in account. But yes, we have to work on that. To stop hormonal therapy because it plays on stress is not something I would recommend. But how to embetter side effects and how to stabilize emotions too. There are some studies on the origins of cancer. As I said before, it's multifactorial. When we find one risk factor, other things will arise. And that is the reason for which I do not answer the question, usually, because if I knew, of course, I would have said everything today. Thank you very much. I think that, thank you very much. We have 4 minutes for questions, and I will pass on the microphone to you. Thank you very much for this conference. I would like to ask for your humble opinion and when it comes to the combination of amoxicillin and metformin. I read a study that stipulated that it helps for recurrence, but as well as it helps with uterus cancers. There are many people who prescribe metformin that also help. There are studies, but it's not something that I live daily. I'm an oncologist, but my colleagues do practice it. I'm not against the idea, especially if there are no additional side effects. If it's something that could be a good treatment, it wouldn't frustrate me. But it is not in our Quebec guidelines to prescribe tamoxifen and metamorphin. Thank you very much. Hello. I think that there are many people just like me who, as soon as you go through this cancerous experience, you're always afraid of relapse. Every mammography, you have this thought. And I was asking myself questions in terms of tamoxifen, the length of the treatment, the 10-year length treatment. What happens if I take it for 10 years? When you stop, what happens? How does the body react? Are the relapse... is the relapse risk higher? I'm a bit afraid. What happens after my 10 years? I'm also wary of taking this medicine and taking this treatment and having side effects. I'm quite in shape, and I tell myself, what happens when I'm tired? Where does my tiredness come from? Why am I always dragging my feet? Why am I always tired? And so what happens on the ultimate day when we stop taking tamoxifen? What happens? How does our body react? Do we have answers towards that subject? Well, to have youth restored, I don't know, but I do know that after taking tamoxifen for 10 years, will affect your body. But also, there are things happening in 10 years physiologically. But you will generate a lot of stress, of course, during that treatment. And so you have to talk about it with your oncologist because that stress will have an effect on the body. But you also have to discuss with your oncologist to make sure that the relapse factor is not a great one. And so you can get rid of tamoxifen. And so if there's another event that happens, well, of course, your oncologist will be there to take you in charge. But you can't live in fear with this question of I'm always going to relapse. My patients do tell me, I understand, but you have to really, you have to put in an effort and declare to yourself that you are healed. It's not easy, but to tell yourself that, that you will find your energy again, that you'll get back to, your infancy type of thing is not possible. People after the treatment are often tired too. Very quickly, we have little time. I will give you the microphone. Hello. For the HER2 positive gene, by taking the hormonal therapy, will we always have this gene present in our system? If you have an invasive cancer with an HER2, you will have a treatment that will not be invasive. But what we'll try to do is to treat the HER2 positive cell. We'll put up a biopsy after to try to see what happens with this cell. But we try to predominantly take care of the estrogen because with the HER2 positive treatment, we do not have a relapse. But usually women have estrogen all of their lives. And so the relapse curve will happen with time. You cannot eliminate the relapse factor at 100%. And this is why we prescribe the hormonal therapy. Any other questions? I would like to get information for the advancements in the new medication that you've talked about and where we can retrieve this information. L'abemacity is available. Abemacity is one of the CD4/6 that is available. You can speak to your oncologist about this treatment. And also, the other one is the process with Canada and the FDA, which will be available soon, probably in the first trimester of 2025. Marie-André, A word to end? Thank you very much, Dr. Asselin, Professor Lausier. Thank you to Suzy Matteau for her testimony. A testimony of her experience with the hormonal therapy. And to conclude, what you should remember, of course, we could have continued our conversation for the next afternoon, but because it's a very hot topic, we could have a whole symposium on hormonal therapy. But what one must remember is to always have proper communication. It's not always easy. It's not all of the team that's receptive to this treatment, and so sometimes you can get a treatment for 12 months and someone then comes up with a hormonal therapy and says, oh no, I don't want that. It is not the best way to attack the subject. I think you should always have a great communication with your care team, whether it is with the pharmacist, the oncologist, or the community pharmacist. There are many people who are available. Family doctor, I think that you have the right to ask questions. And I think that we must ask the question and maintain our communication with the care team and insist on getting the information and our questions. I'm so sorry I'm taking time. Another thing that I want to say is that you've witnessed that there are a plethora of side effects. Many women who have side effects, other who don't. Some people are in the middle. One has to inform yourself well at the right places. With social media, it's easy. There are blogs, but there are groups that are founded by patients, and you have to know it's just like life. Those who criticize, who are growling, who are always more apparent in their complaint, or those for whom for those who are doing well. So we have to give a voice to those who are not doing well, and we have to balance things. If you start and you are proposed a hormonal therapy, my message is to you: try it. Try it, have a follow-up with a care team, and try to see. Maybe you'll be one of those for whom side effects are absolutely manageable. Maybe you'll have side effects. Mention it to your care team. You can change molecules. There are many alternatives. And I would like to tell you, try, and then see and analyze things. Thank you all. Yes, we can actually applaud them. That is true. Thank you very much.